Assalamu alaikum. In the name of Allah, the most graceful, the most merciful. Ladies and gentlemen, we would like to start by welcoming you to be here and thanking you for giving the time to be here and giving us the opportunity and the chance to share you the knowledge, the experience, the awareness, and the change. So, before we start giving the floor to our amazing guest speaker, I would love to ask you a question after telling a very short story. So please be attentive. Once upon a time, two parents went to a doctor, asking for the chance to have a healthy baby after having two unhealthy ones with very incurable disease. The doctor performed the needed tests, and the results confirmed that they have a very, very low chance of having a healthy baby or even a live baby. Regardless of all of that, these parents decided to have the baby. So, my question is, as a doctor, which side you are going to take? Is it the side of medical facts that this pregnancy is risky, a risk that these parents should not take, or the side of the parents and their wish to have the baby? Well, the answer is you should not take either of the sides, because as once a great doctor said, you cannot rule the world with medicine. However, it's still your responsibility, your duty, to raise the awareness as much as you can, regardless of the outcomes. And that is why exactly we're all here today. So ladies and gentlemen, I am Maryam Al-Amoudi, and our CALM project today, as part of Alfaisal Mini Med Series, is Preconception Care. How vital is Preconception Care? And whom is it directed to? And why, which is the most important question. Why should we all know about it? Well, all these questions will be answered by our amazing guest speaker, Dr. Mahan Namir, who is consultant professor in obstetrics, gynecology, fetal medicine, and high-risk pregnancy. So please give a round of applause to our amazing guest speaker.
Good afternoon, and thank you so much for the amazing group and very active group of this Med Series. And thank you so much for the invitation. We'll talk about the preconception care. So, nothing to disclose. The outline would be the definition of the preconception care. And what is a preconception versus prenatal care as a concept and as a medical care? What are the aims of preconception? What is the importance? What are the elements? How we conduct it? How we give it to the patients? What are the challenges to prevent us from providing a good preconception care? And then we'll wrap with the take-home message. So the preconception care is the provision of a biomedical, behavioral, and social health interventions to a woman and couple before conception occur. So in this definition, you notice that it's one-way direction from a health provider to a woman. We thought it's a woman before. We thought only we have to direct our care to the women, but now no. There is a preconception care for men also, for the couple before pregnancy, because we need to get a pregnancy. So the intervention should be directed toward two. And the main element that is, we thought in the previously that we have to take care of only a medical part, prepare the woman for pregnancy, and we're done. We forgot that we have something called social. You have to look to all the social aspects of the patient's life, identify where is the risk, what is the good behavior, what are the risky behaviors, try to change them. Also in their behaviors, in the substance abuse, in the environment, and in the biomedical, including medications as well as diseases, and put them all together, identify the risk, try to reduce them by counseling the patients and educating them, and appropriate interventions if there is. Prenatal care is a health care that's given to a pregnant woman by obstetrician or midwife. So it's the care that's given during pregnancy. While preconception care, I highlighted because this is the most important. It's a set of intervention. It's a care set of intervention that you identify and modify some of the biomedical, behavioral, social risks to the mother, to the baby, or both of them. And it will change also the pregnancy outcome through specific prevention and management. Now, if we go through the links, the preconception health would be the first link which led to a healthy pregnancy, which is a prenatal care, and this is lead to a healthy mother and a baby. The World Health Organization defined a preconception care that if you look for the neonatal life, infancy, preschool, and then adolescence, then adulthood, and then aging, that preconception care given to the women from adolescence to the adulthood. So it's being given during the reproductive years of life. When you give it, the aim is to reduce maternal and child mortality, prevent unplanned pregnancy, prevent the complications of pregnancy and delivery, prevent the stillbirth, congenital anomalies, and preterm birth, low birth weight if we can, and we can, by this intervention, prevent birth defects, prevent neonatal infections, prevent the underweight and stunning, and prevent vertical transmission of many viral diseases, including HIV, and lower the risk for the mother from type 2 diabetes and hypertension. So if we aim for the aims in general, it promotes healthy behaviors like healthy diet, exercise, healthy lifestyle, prevent unwanted pregnancy by implementing a good contraception, increase the awareness about medical problems, identifying them, identify what's the long-term consequences, controlling type 2 diabetes as example here in our community, provide opportunity for intervention early, like if a patient is uncontrolled hypertension, we intervene before pregnancy. If she's a borderline, if there is patient on substance abuse, we can intervene early before pregnancy and stop it. To optimize the health of potential mother by, for example, identifying certain risk factors like anemia and correcting them to have a good, healthy mother, and prevent harmful exposure from affecting a development fetus, either from medications, smoking, or alcohol, or recreational drugs. So if we know now what is a preconception care, we know the elements to whom should be directed. As WHO, we said all women of childbearing age who presented for periodic health examination, whether interested in pregnancy or not. So preconception is not for those planning pregnancy. It's a very important concept to understand. It's not for those planning pregnancy. It's for any woman at any age, whether she's planning to get pregnancy or not. If we don't have a full structure, and we don't have full structure around the world, we don't know how to provide a preconception care, so we called it opportunistic. If you see the woman just in premarital, please take the opportunity and educate her. If you see her for any gynecological exam, routine pap smear, came for vaginal infection, use this visit for preconception care. If she came in with a delayed period and pregnancy test is negative, use this as a preconception care. And even an infertile couple, it's an opportunity to educate them, identify the risk, and intervene. In postpartum visit, whether it's a good pregnancy outcome or poor pregnancy outcome, it's a place where you can provide the preconception care. How you provide this care? The first thing when you meet with the patient, you have to take a detailed history. You have to identify what are the potential risks to the mother, to the fetus, and to the pregnancy. So you ask a lot about social history, smoking, alcohol, drug abuse, risky behaviors, multiple sexual partners, contraception, about healthy diet, weight, what kind of diet that she's consuming, if she's traveling, if she's been vaccinated before or not. So we cover every aspect. And educate the woman about each risk if it's identified. And once you identify specific risk, you can initiate intervention. So, for example, a woman is smoking, you educate about the complication of smoking, and then you intervene by helping her in putting in smoking quitting programs or helping the partner in that. So this is the process how you provide the care. WHO recommend that preconception care given as a bundle, a care set. You have to evaluate all these aspects. The nutritional, you have to take a detailed history about nutrition, vaccination, genetics, environmental health, fertility, pregnancy outcome, female genital mutilation, if it's unplanned pregnancy, sexually transmitted diseases, intersocial violence, and then mental health, psychoactive substance abuse, and tobacco. You have to put it all in the visit, and you have to evaluate all of this. How you will evaluate this? There are many resources available. You either go and take a history yourself, the physician, the midwife, the family physician, the internist, and the nurses in the community. You take a history and you fill it out. If there is time constraint, there is available survey and questionnaires given to the patients. And this is just an example of millions in the internet. There is also a digital form that is you email it to the patients and they fill it out and they send it back. Then when you present to the healthcare, I identify what is the risk in this patient and how I can modify them. So what are the recommended elements? For example, if we go to nutrition, you have to talk to details about the patient. What kind of nutrition? If she's on a well-balanced diet or not? If she's overweight or underweight? How to intervene to correct the weight? Educate her about the healthy nutritional elements. Check her iron for anemia. Check her vitamin B for folate, vitamin D deficiencies, and try to correct it before pregnancy. You have to ask about the alcohol and smoking and substance abuse. And then you have to involve the partner, because you have to tell her that smoking is harmful to the baby, can cause congenital anomalies, miscarriage, preeclampsia, preterm delivery, low birth weight. Even vaping, because women, they think smokeless cigarettes, they are safe. E-cigarettes are not safe. They are exactly like the smoking. It's just less substance, but still it's toxic substance. So vaping also is harmful. Second-hand smoking from a husband also considered to be a smoking. So you have to educate them. Then you have to tell her that any amount of alcohol consumption is harmful to the baby. So there is no minimal amount that is allowed. And you help her through a social, if there is a social or community programs through this thing. You have to review the vaccinations. So if you see teenage girls or premarital, you offer them human papillomavirus vaccination. You have to vaccinate her from rubella, mumps, which can cause severe fetal congenital anomalies before pregnancies. You have to evaluate if she's under domestic abuse, violence in the relationship, depression and anxiety, and you have to refer her to the subspecialties if you identify these risks. You have to review every pregnancy, because sometimes a complication can lead to something like recurrent miscarriages. I did the blood work, turned to be lupus, systemic lupus erythematosus. I refer her to the dermatology. He started the treatment early before she developed the complication of lupus erythematosus like lupus nephritis and cerebritis. See how the intervention? I identified antiphospholipid, the cause of recurrent miscarriages, I managed. I identified for her, for example, uterine anomalies, I referred her to the gynecologist where they removed the septum. So even reviewing the previous complications can help you to intervene to prevent further bad outcome. Also, women has to be taught about the contraception, whether they are married or unmarried. You have to discuss contraception with women to prevent unplanned pregnancy, because unplanned pregnancy might carry a risk that she might go and try to do the termination in a non-medical way and threaten her life. You have to educate them about the chronic diseases. Some people, they manage type 2 as it's a norm. It's not a stigma, it's just part of my life, and they live their life, but they don't know about the long-term complication, eye complication, renal complications, and the complication of long-term uncontrolled diabetes. You have to be involved with them. Then, as a community where the consanguinity, about 60%, so out of 10 couple, 6 of them, they are consanguineous. You have to educate the couple about the risk of genetic diseases. In the premarital, they test for the common ones like sickle cell and thalassemia, but also you have to test and you have to evaluate. Sometimes by history, you discover that they have Fragile X in the family, and it's from only one partner. and then you have to educate the couple before they get shocked by delivering a baby that is sick. You have to discuss with the mother the risky behaviors of teratogenic exposures like radiation exposure, pesticidal, medications, over-the-counter medications. You don't believe, even if you think that you are educated and you're educated enough and people could be educated about the problems. I have a resident that she used the Roaccutane of her husband for herself. She is a resident and he is a resident, and he was given Roaccutane for acne. And she did use it because she thought, okay, it's simple and I could use it, and she got pregnant. And you assume, oh, she is educated, she should know that. But you know, sometimes just you have with high level of education being a resident, but sometimes some in the preconception care area might be missed with the lifestyle and the behavior of just taking the medication of others. Sexually transmitted disease, it's the tableau that we should not talk about it, but you should explore it with the patient in a very nice, non-stigmatism way. You don't stigmatize the patient, you don't judge her, you let her talk. And one behavior leads to other behaviors, so you have to explore it. There is a kit for sexually transmitted diseases, the gonorrhea, the chlamydia, HIV, hepatitis, and you have to explore the patients and discuss her lifestyle, then you do the proper test for that. Managing sexually transmitted disease decreases the pregnancy complication as well as the long-term complication for the patient herself. So the behavioral interventions, like we said, look at her behaviors from smoking and alcohol, domestic abuse. We supply her with a folic acid before pregnancy and we educate them. By the way, it's very important information. A lot of them asking why we have to start folic acid before pregnancy. Folic acid is a water-soluble vitamin. We don't keep it in our body. We don't save it like vitamin A, vitamin D, and E and K. So we don't store it. So why we have to take it daily? Just because it will be a habit. So we want her to have the habit of having folic acid daily. So when she got pregnant, which is usually 46% of them unplanned, she has a folic acid on board. The commonest chronic diseases here, diabetes, hypertension, hypothyroidism. Most of the patients that I've seen, they don't consider at all hypertension and hypothyroidism as a chronic medication at all. Even if you ask, do you have a chronic medical illnesses? No. If you have high blood pressure, oh yeah, it's a borderline. I took my medication on and off. So you have to explore it, have to educate the patient about that. Seizure disorder is very important because the medication can cause fetal anomalies. Obesity is a disease. So discussion with the patient about obesity and the complication, including not limited to miscarriage, low birth weight, preterm labor, preeclampsia, gestational diabetes, gestational hypertension, and increased risk of cesarean section and venous thromboembolism, all of this with obesity. Reducing 5 kg before pregnancy or 10 kg would reduce the pregnancy complication. Also, a very important area that we missed a lot, dental hygiene and dental issues. Periodontal disease, the disease of the gum, can carry a risk of preterm birth, low birth weight. So screening women and managing to refer them to the proper dental care in order to treat them before pregnancy. Genetic, we already talked. Now, medications. I know everybody talks about medication, but when you put it in the practice, you don't know how much patient become pregnant on all of these. Now, the USA Food and Drug Administration defined the 5 risk category from A being the safest, X being extremely teratogenic and not allowed in pregnancy. And all of them start with A for you to be easy to, you can save it. So angiotensin converting enzyme inhibitor like captopril. It's a very common medication that's used for diabetes and hypertension. Antibiotics like tetracycline and doxycycline, mainly for acne, they use it. Acne medication like Roaccutane, isotretinoin, and Retin-A. Anticoagulant like warfarin and anticonvulsant like valproic acid. All of them, they can cause fetal anomalies. And if a patient gets pregnant, if a woman gets pregnant on all of these medication, you know how you failed in the preconception care. You know you failed as a physician, as a community, as a medical society. by providing the proper education and proper channel to help the patient. All the women, regardless whether pregnant or not, should be tested for hepatitis B and C, HIV, syphilis, chlamydia, and gonorrhea. And hepatitis B to syphilis, it's must for all the women. Preconception, premarital, as well as in prenatal. All of them, they will be tested. Why? Because there is an intervention to prevent the fetal complications. Chlamydia, you could see by proper examination of the cervix, to take a pap smear, you could see it's a frothy discharge, and this can cause chlamydia trachomatis and blindness. Now, vaccination. Also, one of the aspects that is you have to discuss with the patient. You have to give her in the preconception care MMR, which is for mom's rubella. Rubella is a very teratogenic. Any woman had rubella infection, we will terminate the pregnancy without even confirmation. It's a highly teratogenic. Varicella, العنقز, الجدري, the chicken pox. All of this, we recommended the woman to have it. Now, for human papillomavirus, we've talked a lot. Men and women should be vaccinated for human papillomavirus, which can cause chancre and cancer in the penile area, and cervical cancer in women. It comes from sexual behavior. HPV is a sexually transmitted disease, so from sexual behavior. So it never comes in monogamous. But we never tell the patient that, because you don't know, so it's properly just to have the vaccination. 5th of November, spoken on behalf of Ministry of Health of Saudi Arabia, they released a statement that is, we have to vaccinate the women. I vaccinated my girls long time ago for HPV when it was available. It comes and goes. It has been in the market for more than 15 years. So a lot of people, they knew about that. In UK, in Australia, it becomes part from the routine immunization. Now, it's very nice what you're saying, but who will provide this care? Anyone could provide the care. So anyone can talk about contraception, either at the level of the community, the primary care center, or the primary obstetrician, or referral. So you can check like how many encounters patient could have. So if she's for contraception or vaccination, she can go to the primary care center or the obstetrician or a midwife, and referral only like if you want to discuss with her, for example, genetic counseling. So if you identified here at the level of the community, she had Fragile X or sickle cell disease, then you refer her to the people. But the whole community can participate in the education. Now, the clinical work group of National Preconception Health, they put the measures for successful preconception care. If you have a successful program, the first prenatal visit, the woman would have these elements. She would have absence of tobacco, so quit smoking. She would have optimal glycemic control. She would have no, or at least control the depression, so on treatment. It would be a planned pregnancy. This is as a successful preconception care. A woman would have absence of any sexually transmitted disease. The woman would have the first prenatal visit before 12 weeks. A woman would have no teratogenic exposure, and she had a folic acid supplementation, and she adopted healthy weight before visit. So to have a successful preconception program, when a woman presented to you pregnant, all of these has to be there. And all of these came from what? From your intervention before, the one we said. Locally in Saudi Arabia, what we have? We have only this. So out from the whole care set, even preconception care at King Faisal, we offer only this one. Imagine how much we are lacking. All of these aspects we never talk about. Never. We only bring her for genetic counseling. So why? Why is that? What's the challenge? Why I cannot provide a good preconception care? From the doctor's midwife, we have time constraint. We have no time to complete the other task. I have OR, I have other clinic, I have student to teach, I have on-calls to do. I can't bear you put me an extra work on me. For the patient, the lack of awareness and education, that is important. So they can't ask for their rights. Make sense? They can't. If it's not important, we don't know it's important. For the healthcare system, The lack of resources, no enough physician, no enough primary care centers, no enough material to give it to the patient, no enough brochures like the girl, they did it beautifully, it's written. And if it's written in English. And we did not use the applications and these nice apps. So the healthcare system deficient in all of that. And on top of that, the healthcare, the health insurance in different hospitals, they don't provide, even in the state, they don't cover the preconception visit. There is no code for preconception visit. Nobody would pay for it, and nobody would pay for the investigation or the preventive measures that you want to intervene. So all of these are global. It's not only in Saudi, it's a global. Even in the state, there's a problem in providing the care. The last thing, WHO put a strategy. If you want to implement a preconception care in your country, how you will do it? What's the implementation strategy? You pull the people, you put the assets, you set specific goals and put expertise on top of that, like what we did with Mawsim al-Riyadh. So we did it great. Within 2 months, it's a Riyadh season is ready. So exactly, we can do it. It's doable. We need just resources, we need money. So once you have the budget, you do it. You announce it, you put it in the media, and you start educating the patient. Patient will push you to give them this right of preconception care. The last slide about taking home message. Every woman of a reproductive age who's capable of becoming pregnant is a candidate for preconception care, regardless whether she's planning to get pregnant or not. The preconception care aims to identify the risk, modifying them, all the biomedical, behavioral, social risks through the preventive and management options. Thank you. Questions? Okay. Sure.
Assalamu alaikum, everyone. We're opening the floor for questions. Feel free to ask. I think we're going to start with Dr. Hatouf, right?
Assalamu alaikum.
Alaikum assalam.
Thank you so much. That was very interesting. I'll tell you, because I'm a very, very open person. I express myself openly. When you started the talk, I was like saying to myself, oh my God, so many things we're not doing, and this is not realistic. And you sort of made it up towards the end that, we're lacking things, so we are trying to admit it, which is great. And everyone here should start with change. And change basically starts with, thankfully, Dr.Baraa invited you to increase the awareness amongst our students who did not even graduate, to make sure we think about this early on. We trigger the question and start having ideas of how to change and how to implement. And we always think when we do any project how feasible it is. So any of the projects or any of the research done had like feasibility of how much we're saving lives, saving money, for these insurance companies to start doing some work, because it all starts with money, unfortunately. If something is not covered, no one will practice it. And the other thing is the role of the nurses, the role of the team around the doctor, because definitely the doctor doesn't have the time to do all of this. It's a lot of work. So can we do something about empowering the people around the physician, of doing either asking the patient to fill up surveys, trying to ask questions before they get into the doctor's clinic, so we can do something about it. And thank you so much.
Thank you, Dr. Hatouf. It's a very nice. You covered 3 points in your question. The first thing that is, if there is any work being done, yes, WHO published the interventions in African country. They told me it's limited, so that's why I did not increase my slides. Otherwise, you can talk about preconception care the whole day. So in Africa, they've done it already. What they did, they've checked the pregnant women, the complications, and the neonatal death, the stillbirth rate, and the risk of sexually transmitted diseases and the HIV transmission, which is the biggest project in Africa. And by preconception care, yes, we did. We did reduce. WHO, I'm talking the head of WHO, they did reduce. So your intervention can be translated to reduction. Now, WHO done it in African country because it's easy and is not that much costly. The second thing that is you touch on, is it feasible here? Of course it's feasible. But I'm not trying to be pragmatic, but we don't have a healthcare system here. We don't have primary healthcare, right? So if you can't have a primary healthcare, now, if I'm sick, I don't know where to go. I go to King Faisal, tertiary care center. My mother is sick. I don't know where to go, right? In the other countries, if you're sick, you call your family physician, you take an appointment, you go there, get checked, he gives you medications, right? My daughter has a fever, shivering, and strep tonsillitis. Still, I see my family physician. We never go to the hospital. So the healthcare pyramid was different. If I have a runny nose, I would go to King Faisal. That's the only thing. The military, they go to the military hospital. Security forces, they go to security forces. University, King Khalid, they go to university. So we don't have a primary health care for our medical care rather than preconception. The third thing that is, who can provide preconception care? Anyone. Of course, it starts with the midwives. Midwives and nurses are the first one. Medical students would help in the clinic if they do a rotations. So filling patient, they can fill it by themselves. The question is, who identify the risk? Filling is not important. Is risk. There are risks not modifiable. Like if you are carrier for Fragile X, you are carrier for Fragile X. If you are carrier of sickle cell, you are carrier of sickle cell. That's it. There is a modifiable, like a bit, smoking, unhealthy diet, lazy life, I'm not doing exercises. So the physician has to go over them and say, okay, you Fragile X, I'm gonna refer you to the genetist for counseling, but you, I can put you with a community program for more education, weight loss program, quit smoking program. So yes, anybody could do it.
Doctor, you talked about some drugs that should not be given to pregnant ladies. Are they all X?
Yes, the one I mentioned, yes. Yes. There are certain medications, just for your knowledge, like valproic acid. It is a teratogenic medication. It's a class D. We gave it to the women who cannot control her epilepsy. So we tell them, the preconception care, the right one, the patient never comes pregnant on valproic acid. But if she comes, that's we deal with it. However, the preconception care, you go to multidisciplinary with the neurologist. So with her obstetrician, she should be off seizures for 6 months. Then he'll try to change it to another safer medication because she's planning to get pregnant. And then he monitor if changing the medication that she would have another fit or no. If she's free, they said, okay, I change your medication. Now you can get pregnant. That's the ideal preconception care.
Thank you. Thank you, Dr. Maha, for giving this. I'm here. Thank you, Dr. Maha, for giving this nice lecture and for increasing the awareness among Alfaisal University students and faculty. And thank you, Dr. Baraa, for organizing this lecture, for the nice setting and the nice colors. Thank you so much. Dr. Maha, my question is, I would like to ask you, so for this preconception visit for the first time, both the potential mother and father, they should go and visit the doctor, or only the potential mother should go and see her?
It's always couple, always. So that's why if you go deep, you will find preconception care for women, preconception care for men. So men, in what way we are intervene? So there is also nice saying, you know how in the Western people said, we are pregnant, we are pregnant. So use we. It's a good thing. We need two people to get pregnant. So preconception care for men involving the same. It's avoiding of substance, quitting smoking, get weight. The most important, Sarah, it's also environmental. If he's on medications that can cause teratogenicity, we stop it, affecting the sperm quality from the fertility, you try to change it or modify it. If he has a diseases, also like diabetes, it just encourages awareness, because diabetes in the long term or medication of hypertension can cause impotence, can cause infertility. So preconception care for couple is not for women, it's for couple. But everybody thinks preconception means pregnancy. This is a wrong idea. Preconception has nothing to do with a pregnancy. Has nothing to do with it. I can give a preconception care for a 16-year-old single, because you are tackling different. So why we call it preconception? Because we don't have a teenage clinic, premarital clinic. So we said, you know what? It's a preconception, because it's anything before you are not pregnant. That's the idea. But yeah, it's for the couple, both of them. Yeah.
I will bring my husband and to see you.
Any other questions? I think we are okay.
Yeah, I have a question. I think so this is really important. The topic is really important. But in your opinion, how can we increase people's awareness about it? Because pretty much everybody knows about this. So what can we do to increase their awareness?
Thank you. It's a very nice question. I always believe, I have this belief in my practice. Always I tell the patient, you know what? If I educate you, I know I'll change you, and you'll change the circle around you, which are your mother, sisters, and friends. And I educate the other one, and your sister will educate another one. By the end, the whole circles will intersect, right? I started on Twitter like 3 years ago. And I've been putting a lot about HPV vaccination. I thought it never caused a ring. And you know what? The stack of Gardasil and Ceravax was in Al Habib and in Kingdom Hospital and in other hospital, even King Faisal. It was stacked. Nobody's using it. But it's just simple tweets. You keep repeating them. You keep increasing the awareness in a small, like person, see how much. After that, any premarital, we don't have HPV. We don't have vaccine anymore. It's finished. So we have to buy it from outside. Now I'm doing the awareness about the cell-free fetal DNA for trisomy 21 Down syndrome screening. So I have been putting these tweets. I think, and Amaha, I believe, if we start from the media, because I believe the pyramid is different. If the population pushed us, we will provide the service. That's how I believe. So if we increase it in the media, the population will increase the demand, and they keep asking about that, and then every healthcare sector will provide at least one clinic. We can spare one clinic. We have a lot of obstetric clinics, right? We can spare one clinic, call it preconception clinic. I think, so increase awareness, spread the word, put it in brochure, in apps, and in the media, of course, under the government, not me. But I mean, if everybody's talking, then the government will take that. Like government, how come the government will came with this one, with this idea? We never thought they will. We never thought about the HPV. It was 7 years ago in UK as a standard vaccination, right? But the push of the media keep asking, where is the HPV? We want HPV vaccination. Everybody, and that's why they said, okay, we'll provide it to you. I know the MOH have a lot on their plates, and they can't provide. They need the money for more serious things, like diabetes, hypertension, the chronic diseases in Saudi. But I think the community, so spreading the word, increasing talk about it in the media. You are in the campus, everyone would go telling brothers, sisters about the preconception care. The word of the mouth will spread, and then we push it. And otherwise, we have to wait for the hierarchy to choose when they start. But I think the community can push for this thing. It's the right for every couple to have the preconception care.
Thank you, Dr. I have also to thank the students for such a brilliant idea, and it was the topic that they showed themselves to raise awareness. And hopefully we are starting now with, with this sort of initiative, and they're planning, I think, to go further and maybe start a larger campaign at the public health level to raise awareness about such an important topic to the entire community.
Excellent.
So thank you so much.
Thank you, Dr.
Thank you. Simple gesture. Thank you so much.
Thank you so much. Thank you so much, Dr.